going to talk a little bit about the Affordable Care Act, and as the U.S. Supreme Court deliberates about where it is going to come down in terms of the constitutionality of it. But what I'd like to talk to you about is a lot of the debate on this issue has centered around the so-called individual mandate, the provision that requires all adults to buy health insurance either through their employers or by buying it themselves. Can you talk a little bit about sort of your views on this provision and sort of your feelings on it?
Absolutely. I mean, I think this is ultimately one of the key features of this approach to health reform, which is in the Accountable Care Act nationally and then was in Massachusetts previously. In some ways, it's what makes it a kind of middle of the road type of policy approach. You know, it's not at the extreme of just having, say, a single payer system, and it's not at the extreme of just saying, well, everyone's in it for themselves, because ultimately it recognizes the relationship between my decision to purchase health insurance or my decision not to purchase health insurance and then go to the hospital if I get sick, and the implications for others. It's basically the individual mandate ultimately is it's very similar to a tax in many ways, but basically the simple idea is that if at the end of the day you don't have health insurance, you pay a penalty. And it basically is you can think of it, I think, in some ways as kind of a nudge towards getting health insurance, right? So at the end of the day, depending what the Supreme Court does, if I don't have health insurance, that's still my choice, but I will pay a penalty, potentially and arguably commensurate with sort of some cost I'm imposing on others. But ultimately, I don't have to do it. It's not a mandate in the sense of kind of everyone will be forced to do this. And in Massachusetts, a very similar thing occurred, and in fact, you did see a big effect amongst the people who were uninsured. About half of the newly insured were gaining coverage through their employer. And so one argument there is that what the individual mandate was doing was really just augmenting some underlying value for health insurance. Maybe, people valued it a fair amount, just not quite enough to take it up. So say I said, well, every dollar of health insurance I get, 90 cents of it is worth it to me. That's not enough to make that trade-off. But then you add on the individual mandate, and it kind of puts you over the hump, as it were. So I think it's a new policy tool broadly in the health reform and health insurance debate, but it's been tried in Massachusetts, and it's obviously a fairly critical keystone to the national reform. The other big piece on the insurance side are the substantial subsidies which exist, both expansions in traditional Medicaid for people under 133% of the poverty line, but then subsidies for insurance gained through the various state health insurance exchanges, and that will go up to 400% of the poverty line. So lots of people will have potentially access to some form of subsidy. So those are the kind of two pillars that really are intended to augment the expansion in health insurance.
Now, if the court strikes down the individual mandate or even the whole act, what would that mean for healthcare going forward? Can other aspects of the act stand without the individual mandate? Or if the entire act is struck down, what does that mean for businesses, for consumers, or even for Congress and the Obama administration? I
think absolutely. This is a critical question, and obviously one of the fundamental questions from a legal perspective the Supreme Court is facing is can the rest of the statute stand without the individual mandate in it? And at a very simple level, the individual mandate is very important for facilitating basically pooling in the insurance market. And the problem occurs if one of the other key pieces of the ACA is the fact that basically the prohibition on pricing based on pre-existing conditions or not offering coverage. And that, of course, is a very popular and potentially very valuable tool. It effectively prevents people from facing the risk of becoming reclassified. So right now, it may be that if I get very sick, I can still get health insurance. But if my premiums go up substantially, then I would like to even insure against that. And so if you basically pool everyone, you've improved welfare by overcoming that problem. The issue is that if you don't have any way to actually get everyone into the pool, and you can't price based on pre-existing conditions or price based on health risk, then in fact only the sickest people will decide to come into the insurance market, and that can potentially lead to rising premiums and even in the extreme kind of the individual insurance market unraveling. Now, there is some evidence for that at different state levels, and you have seen, for example, in Massachusetts, when they implemented the individual mandate, you did get healthier people into the pool And in fact, they had, at baseline, they had basically guaranteed issue and community rating, which ostensibly looked like the other pieces of the ACA without the mandate. And they did see some reductions in, or the newly insured were significantly healthier than the previously insured. So there's some evidence that the insurance market would be, or there would be difficulties in operating the insurance market in the absence of the individual mandate, but with the existing provisions that limit the ability of insurers to price an underlying risk. The other important piece that I did bring up is the subsidies. It might well be that with very substantial subsidies, you are able to expand insurance coverage substantially and potentially these issues with adverse selection will not be as problematic if you are able to facilitate, for example, a subsidy gets in relatively healthy folks into the pools and into the markets. And it also depends on how insurance exchanges are set up. So that's one key feature which is in the ACA, but each state is setting up their own health insurance exchange, and how that functions and how that works is going to be really critical to what insurance is available, who signs up, who enrolls, even conditional on kind of the overarching structure, which is in the ACA now and will be determined to some degree by the Supreme Court's decision. So on the insurance side, I think it is very fundamental, though arguably those other provisions can stand in the absence of it. There are also key features that are, I think, not the focus of the reform, but things like the accountable care organizations and changes to the payments for delivery of care that arguably are very critical going forward in thinking about new models to address the cost of care, the appropriateness of care, the effectiveness of care, that potentially are largely unrelated, or certainly are almost largely unrelated to the expansions in coverage, which are the keystone of this reform. And I think they arguably should be. In the U.S. we have roughly 50 million uninsured. That's kind of a first-order issue of to deal with that. But ultimately, we all know that the growth trajectory of healthcare costs relative to GDP is a big issue. And one argument has been to change the incentive to try to deal with that. And there are a number of provisions and demonstration projects and new approaches in the ACA that I think would be important to try, and it would be, I think, a setback to our understanding of the policy options to deal with healthcare costs if everything was thrown out and we weren't able to implement things like accountable care organizations or other forms of bundled payment that might potentially incentivize higher quality, lower cost, or both by physicians.
So, given that almost everybody agrees that healthcare in the country is too expensive and getting more so every year, plus it doesn't cover, as you said, I think it was 50 million people. What would be one thing that we could do to tackle rising healthcare costs? Is there something, particularly maybe something that's not in the act, that you could see that would probably make a big difference or an impact? Well,
I think there are features of very important issues in the act. There is an important thing to remember is that we get a lot for what we spend. So we live longer and healthier lives today than we did in the 60s, and we spend more on healthcare. And on average, we may be very willing to have made that trade-off. Now, that doesn't mean that healthcare cost is not eating up a larger and larger share of GDP. And in fact, we can observe there are very wasteful things. So the question, of course, is can we sort of have our cake and eat it too? That is, can we cut back the wasteful stuff without really undermining those incentives that ultimately I think we all value for ourselves, for our families, that you can go into the hospital and get treated effectively for things that you couldn't have been treated for even 10 years ago now. And most of what's driving cost growth is those new technologies, are those new treatments. And one important feature there is potentially aligning the incentives of providers to provide high-quality, low-cost care and not to be rewarded for providing just the most intensive care, but arguably the care that provides gains in health while not incentivizing additional technologies or additional intensive procedures. And there are features in the ACA that are intended to at least address this in some degree within Medicare, which is kind of thinking about bundling payment or accountable care organizations, which I think are at least steps in the right direction. And that is to say, if you are giving physicians basically strong incentives to reduce cost, but the key feature that I think is unique and potentially positions us well is that today, as opposed to, say, when managed care was first really on the rise, say in the early 90s, is that we have substantial expansions in healthcare information technology and the ability to actually measure quality and quality of care in a lot of different conditions. Not all conditions. It can be very challenging, much more effectively than we have been able to in the past. And so if you combined, potentially strong incentives to lower cost with very strong incentives to provide high quality care, the confluence of those two things is potentially a powerful mechanism to really kind of align incentives to approximate kind of what we would think the market would offer. If I go and buy something at the store, say I go buy breakfast cereal, we're not concerned about me making the wrong decisions or my decisions not reflecting sort of some optimum. Whereas in healthcare, the information problems, namely that I don't know what I need and I'm relying on a physician to both inform me as well as sell me those goods and services is a problematic. And then they're being paid by an outside, a third party. There is an argument that with information technology and with new incentive models, we might be able to actually at least begin to approximate the appropriate incentives and try to cut out those sort of marginal services which are of low value while leaving intact the fact that we do like, I think in general, the hospital University of Pennsylvania is right there. I like the fact that I can go to HUP if I get very sick, and I think most Americans do on average. So trying to align those incentives while keeping intact what we have that's functioning quite well, I think those mechanisms and the combination of IT and incentives might be able to accomplish that.
Now, you've done studied extensively healthcare reform in Massachusetts. Can you say, is there any initiative there, any lesson learned there, even other places that you think could be really impactful at the federal level for us to consider?
Absolutely. I think there's a number of interesting lessons in Massachusetts, and some of them are ongoing. So in many ways, Massachusetts was focused on kind of the former piece we were talking about, which is Massachusetts was largely about insurance, and the ACA is largely about insurance. Massachusetts is now beginning to think about some ways to potentially tackle the cost growth and the fact that Massachusetts has had cost growth and in fact has had cost growth that has exceeded other states before their reform and after their reform. So I think there will be interesting lessons coming out of Massachusetts there, but certainly from the perspective of the individual mandate, the employer mandate, and subsidized care, the mechanisms in Massachusetts mimic very closely the sort of key structures of the ACA, depending on what the Supreme Court does. And I think there's a couple important lessons. First is there is a fair amount of evidence from Massachusetts that basically the provision of insurance to the new, basically 6 percentage points new people, of the population gained health insurance as a result of the reform. And there was evidence that basically they were using the emergency room less, both for outpatient visits and visits that eventually resulted in the inpatient inpatient admission. There was also some evidence that they were basically getting access to outpatient care that could prevent hospitalizations. That's a little more mixed, but certainly some initial evidence for that. And so I think there are some early signs that given our system, providing access to insurance can actually make a more efficient delivery of health care and potentially maybe lower cost, but certainly improved health, which is of great value. So that's I think an optimistic lesson from Massachusetts. The other big lesson relates to the function of the insurance market. And as I was saying earlier, we've done some work and there is some evidence that when you implemented the individual mandate on top of an insurance market which had community rating and guaranteed issue, you did find that the new enrollees were differentially healthier, at least on hospital costs, than the prior enrollees. And that is suggestive of some degree of adverse selection in the absence of an individual mandate. And it does suggest that's an important aspect. Now, of course, Massachusetts' overall insurance market was functioning reasonably well, but their individual market was very, very expensive prior to the individual mandate and was not functioning very effectively. So I think the individual mandate could be quite key if you really think we're going to rely on exchanges and acquisition of individual health insurance to facilitate expansions in coverage. Now, the other lesson from Massachusetts is, in fact, that when they did implement the reform, about half of the newly insured gained coverage through their employer. And so that is, I think, not as consistent with a lot of the kind of projections for national reform, but I think that some of those projections are missing this underlying feature which I was talking about earlier, which is people value health insurance. Even if you don't take it up, you don't think of it as something that's totally worthless. And so when you implement an individual mandate, in some ways that just augments the underlying valuation. And if in fact your employer can be, is providing you a benefit that you see as something that is well matched to you and something you value, then the combination of your value for health insurance and the individual mandate can actually be a powerful incentive to get people to take up their existing employer-sponsored health insurance. And that seems to have happened in Massachusetts. So in some recent work we've done, we found that the newly insured in Massachusetts were willing to accept wage reductions on an average of $6,000 per year to gain employer-sponsored health insurance. And that accords almost exactly with the cost to their employer of providing that insurance. So implicitly, that basically suggests that the combination of their underlying value and the individual mandate that induces a valuation led them to basically value the health insurance benefits they received almost fully. And that made it an incredibly efficient mechanism to expand health insurance, because effectively they were able to piggyback on the existing infrastructure, expand coverage to that additional population, and distort the labor market very, very, very minimally. And so I think there are some lessons that suggest that this can be a very efficient tool. And so I think there's obviously legal questions which are critical in determining, the Supreme Court is focused on. But from an economic perspective and a policy perspective, I think it would be a major setback if we lose this tool as a mechanism for public policy, as well as kind of undermine what is a big step forward in terms of health policy. We've been trying for 100 years to have some sort of comprehensive form of coverage, and I think we are relatively close at this point. And there is some evidence from Massachusetts that this could be an effective, middle-of-the-road way to do it.